Over the last 4 decades, the number of older adults taking 5 or more medications daily has skyrocketed. But such polypharmacy in older adults increases the risk of adverse drug reactions, drug interactions, and medicated-related problems. This is largely due to the normal decline in renal and hepatic function with age, making it more likely that patients will experience higher plasma levels of each drug, causing more drug interactions. Polypharmacy also increases the risk of a patient making mistakes when taking their medications. In this MedMastery lesson, we'll discuss 6 steps for managing medication burden in older adults. These strategies will allow you to thoughtfully prescribe and deprescribe medications to maximize and maintain function in your older adult patients. The first step in reducing polypharmacy is to identify and stop medications that may not be necessary. Older adults are more likely to have multiple care providers. It's common for a medication to be started by one provider and stay on the active medication list for years or even decades without anyone knowing why it was continued. For example, a patient may have been started on baby aspirin 10 years ago for a diagnosis of diabetes, but this is no longer indicated under the guidelines for diabetes care and can be removed. Medications without clear indication cause increased side effects and increased potential drug interactions. You should discuss ways to stop these medications with your patients, recognizing some medications will need gradual removal. The second step in reducing polypharmacy is to identify the use of redundant medications. Using more than one medication to treat the same disease increases the risk for side effects and drug interactions. Common diseases where we find redundant medication use include bladder incontinence, depression, pain, and hypertension. Let's take a look at a common regimen for blood pressure management. In this example, an 85-year-old patient is on 4 antihypertensive medications. They were started on metoprolol and lisinopril with suboptimal control and widely fluctuating blood pressures. Amlodipine was added and caused ankle edema, so the patient was prescribed hydrochlorothiazide. Can you think of a way to reduce the number of prescriptions and optimize doses to avoid polypharmacy for this patient? Let's pause for a moment. Well, if we stop the amlodipine, there's no need for the hydrochlorothiazide, and we can increase lisinopril to twice daily dosing to better control this patient's labile blood pressures. The third step in reducing polypharmacy is to identify drugs used in higher doses than necessary. Older adults often need lower doses of medications than younger patients. As we age, not only does our liver and kidney function decrease, but our muscle mass declines as well. A good example of this is pain medication. You may start a young person on 300 milligrams of gabapentin 3 times a day for neuropathic pain. But for a 78-year-old woman, you would want to start her on 100 milligrams at bedtime because of the risk of drowsiness, dizziness, and falls. The fourth step in reducing polypharmacy is to identify and stop medications that have significant side effects. Because of the physiological changes of aging, managing medication side effects in older adults is much more difficult. For instance, older adults generally have slower colonic transit, so drugs that cause constipation are poorly tolerated. And medications that can cause dizziness or drowsiness are less tolerated in older adults who may have issues with labile or postural hypotension or mild cognitive deficits at baseline. The fifth step in reducing polypharmacy is to identify and stop medications that decrease function. Most geriatricians would argue that functional status is the most important measure of quality of life for older adults. When we look at what matters most to our patients, maintaining function and independence is at the top of their list. 2 of the biggest threats to functional status are falls and delirium, both of which increase the likelihood of frailty long-term. Older adults are much more likely to experience delirium as a side effect of medications. Common classes of medications that can cause delirium in older adults include analgesics, anticholinergics, antidepressants, steroids, hypnotics, and other medications that act on the central nervous system. While many of the same medications increase the risk for falls, you also need to consider the more common medications that indirectly increase fall risk by lowering blood pressure, increasing the risk for orthostasis, or increasing urinary incontinence. Because rushing to the bathroom is one of the most common causes for falls in older adults. The sixth step in reducing polypharmacy is to identify and avoid medications that increase morbidity and mortality. Some medications have significant risks related to morbidity and mortality. For example, antipsychotic medications, which increase the risk for cardiovascular events and even death in patients with dementia, and shouldn't be used without a thorough risk-benefit discussion with family and caregivers.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.